Good evening, everyone. Thank you so much for taking our time and joining us today for another session of Child Mental Health Community of Practice. And the topic for today's session is eating disorders. We would like to start today's session by acknowledgement of country. Northwestern Melbourne Primary Health Network would like to acknowledge the traditional custodians of the land on which our work takes place, the Wurundjeri Woiwurrung people, Boon Wurrung people, and Wadawurrung people. We pay respects to elders, past, present, and emerging, as well as pay respects to any Aboriginal and Torres Strait Islander people in the session with us today. Before we start, just some community of practice guidelines for people who are joining us for the first time. So we agree to stay on mute unless speaking. Raise your hand to speak. Keep conversations confidential. Please try to keep your camera on. While speaking, please introduce yourself and your role. Share ideas and promote everyone's participation. We are a diverse group of people attending from different backgrounds, so acknowledge that we have varied learning needs and interests, and please ask questions. One of the important part is that during the education component, please ask questions via the chat box. The session is being recorded. It is important that you join the session with the name that you have registered with, so we can mark your attendance. And just a little bit on how you can change your name in the Zoom meeting if you have already not entered with the name you registered. So you click on participants. If you're joining from an app, click on your name. If from desktop, then just click the three dots. And if you're joining from Mac, then just hover over your name and click more, click rename, and you are done. And our psychiatrist, facilitator and presenter, Dr. Prakash. He is a senior consultant child and adolescent psychiatrist at RCH with over 20 years experience. He has worked in and managed general and specialist clinics within child psychiatry in metropolitan and regional public mental health services. Prakash has worked with children and adolescents from 4 to 18 years of age, assessing and managing a variety of mental health issues. I'm Saha. I have been working as a GP for about 10 to 11 years, and my areas of interest are child and adolescent mental health and chronic disease management. We are very fortunate to have really excellent guest speakers with us today. Dr. Michelle, she's from RCH. She's a pediatrician and physician in adolescent medicine. She has a long-standing interest in eating disorders and is the medical lead for RCH's eating disorder service. She enjoys working within a multidisciplinary team and opportunities to teach. Her other interests include chronic illness and health risk behaviors. We have Matt with us. He's a pediatric dietitian working within the adolescent medicine department and the Children's Cancer Center at the RCH. He has worked in the area of eating disorder for the past 7 years with experience in regional community health and metropolitan inpatient care with adults and adolescents. He takes particular interest in the nutritional rehabilitation of young people, beginning their recovery pathway and providing education to families on how best to support their young person experiencing an eating disorder using a food-first approach. Let's have a look at the agenda for tonight before I hand over the mic to Michelle. Thank you, Michelle.
Hi, everybody, and welcome. So happy to take questions as we go along. I'll start off by providing a little bit of an introduction into eating disorders, but particularly focusing on the restrictive eating disorders, which is what we mainly see at the Children's Hospital, and try and provide a little bit of background and, I guess, diagnostic clarification around some of the disorders. So if we go to the next slide, please. That's a picture that's drawn by one of my patients, and unfortunately, you know, how she saw herself, which was ugly, which was a bit sad because she was definitely not ugly, and you know, bright and chirpy and very, very attractive. But that was how she saw herself. I'd just like to start off by just saying that, you know, screening tools are not terribly sensitive or specific for eating disorders in adolescents. And actually the most effective screening device is all of us thinking about the possibility of an eating disorder whenever an adolescent presents with eating problems or weight loss, and sometimes even gastrointestinal complaints or menstrual complaints as well. So we go on to the next slide. So I'm going to talk mostly about anorexia, talk a little bit about bulimia and avoidant restrictive food intake disorder, which is ARFID. We don't see a lot of binge eating disorder, but that is largely managed by the weight management clinic when young people present with overweight. We see a little bit of rumination disorder, but I don't have enough time today to talk about it. And every so often we see pica. So concentrating mostly on anorexia because that causes significant morbidity and mortality. Bulimia, we don't see a lot of, unless they're very unwell and they present to tertiary hospitals because of electrolyte disturbances. If we go to the next slide. So what we know is that adolescence is the peak age of onset for eating disorders. Certainly is the third most common chronic illness in the female population after asthma and obesity. And it used to be thought of as a white, kind of high income disease. However, I think over the last 20 years or so, what we have known is that eating disorders do affect all ethnicities and social groups. And at the hospital, we even see patients from a refugee background presenting with eating disorders. And sometimes that's a bit of a challenge because they often come from countries where food security is a problem, and their parents often find it really hard to understand why they have actually come, rejecting and restricting their intake. So with anorexia nervosa, the lifetime prevalence is about 1 to 2% in females. And of that, about 10% of that are in males. We think that overall incidence is stable, but has been increasing in the younger population. What's interesting also to note, particularly, I guess, in your practice, is that anorexia tends to present much earlier than bulimia nervosa. Bulimia lifetime prevalence is a little bit higher. We'd say probably about 2 to 3%, I think, and of that 0.5% is in males. And they tend to present in the older adolescents. And actually phenotypically and genetically, there's quite interesting clusters. So bulimia tends to be associated with much more of the impulsive subtypes of presentations, whereas anorexia tends to be associated with young people who are much more controlled, so the perfectionistic kind of personalities. And with bulimia, it's often secretive, so they often don't get noticed, and because the weight loss is not that noticeable, they don't present until much later as well. Next slide, please. And I would imagine that you would have also seen the uptick in numbers during and after the COVID pandemic in terms of young people presenting with eating disorders. We actually saw a doubling of our numbers over the COVID period. And what's also interesting is that the numbers have been replicated in studies worldwide. So there were increased numbers presenting to emergency departments, outpatients, and hospital admissions, and also in general practice. I think coupled with that is also an increase in the complexity of the types of patients that have presented, so that I think they're not always a pure anorexia presentation anymore, and many present with significant comorbid disease. So I'll go and talk a little bit about what anorexia is. Essentially, anorexia is an illness where there is a restriction of food intake, such that it leads to weight loss. And in children and adolescents, the weight loss is actually abnormal, because they are expected to grow during this time. And what we know is that it's important even to look at growth in this context, where in children and adolescents, they meant to be gaining weight. So even flatlining or not gaining weight whilst their height is increasing is also problematic. There is an intense fear of gaining weight or becoming fat. And in some cases, you might not see they might not be able to articulate that intense fear, but there's behavior that interferes with weight gain. So, lots of excuses like I'm not hungry, I'm tired, I'm not going to eat, I've got tummy ache, I won't eat, I'm nauseated, I'm not going to eat. Then there is this disturbance in which one's body weight or shape is experienced. So it's the body image distortion, the feeling that they are fat. That's why that drives the weight loss. And there are two subtypes. There's a restricting subtype and a binge purge subtype. And I think what is important when you look at anorexia is the qualitative kind of drive for weight loss. It's an incessant drive to just keep losing because of this body image distortion. Atypical anorexia is actually coined because young people are not underweight, so they may be normal weight or they may be overweight, but they've actually lost weight. And all the other criteria are the same as for anorexia. So these have the same drive for weight loss, but often because they come from a higher weight, so they may have been overweight before, and then they've lost weight, and then the anorexia switches on, but they've come to you with actually seemingly normal weight. And it is thought that these young people are actually, psychologically sicker, and they physically can be much more unwell than those just presenting with AN itself. Next slide, please. So with bulimia, it's what the pattern is. It's that there is binge eating, and because of the intense guilt after binge eating, there are inappropriate compensatory weight control behaviors such as purging or laxative use. There is a time which you need to tick off in DSM-5 for the diagnosis, so it needs to be more than once a week for 3 months. Anorexia is not there. So the drive for weight loss, even though they are unhappy with their weight, the drive for weight loss is not there, and it's not quite as marked as in anorexia. And how you differentiate that between binge purge anorexia and bulimia is that over time, you will see that weight kind of marching downwards, whereas with bulimia, you see the yo-yoing back and forth effect when they binge, and then they starve themselves because they think, I can't do this. binging is bad, I'm going to starve myself. So they starve and then they can't hold out, they binge again. So you see this yo-yoing of their weight. Next slide, please. Quickly talk about ARFID. So ARFID is a problem with feeding or eating and its restriction of intake, leading to weight loss or inadequate nutrition. And then it has to fulfill one of these criteria. So in children and adolescents, either weight loss or failure to gain weight, they may result in having a major nutritional deficiency, or they may need to be dependent on nutritional supplements or nasogastric tube feeds, and a marked interference with psychosocial functioning. They don't have body image disturbance at all. It cannot be due to scarcity of food, such as in neglect or fasting due to religious reasons. And it cannot be explained by a medical problem or psychiatric disorder, such that the eating problem resolves when the medical or psychiatric disorder is treated. So let me give you an example. It frequently can coexist with depression or anxiety disorder. However, if you actually treat the depression or anxiety disorder and the anxiety disorder has improved significantly, but you're still left with that eating problem, that is ARFID. I'll give you another example. So ARFID can also exist with gastrointestinal problems, such as inflammatory bowel disease. And if you treated the inflammatory bowel disease and they still complained of pain, or discomfort or bloating or nausea, you do a scope and actually the scope looks pristine, but they've still complained of pain, nausea, and can't eat, that is ARFID. Next slide. ARFID presents in three different ways, and sometimes they can overlap. So the first group is sensory food aversions. So these young people are often, or children, are very sensitive to the taste or the smell or texture of certain foods, and they can eat a very restricted range of foods. So, and this is common with the autism spectrum disorder population. The second group are those kids that have, no drive for eating at all. They have a low appetite, early satiety, and the parents will say, they've never been interested in food all their lives. They always have to be dragged to the table to eat. And then when they do eat, they only eat minuscule proportions and then they're off and they're just not interested at all. And what you often see with this group is that there's a, this very long-standing pattern, right from the word, in their toddler years. And then the third group presents much more acutely, where there is a fear of aversive consequences. Sometimes it comes from a choking episode or vomiting episode or anaphylaxis. And because of that, they become very anxious and find that they can't eat afterwards. There's another group that present with gastrointestinal symptoms such as pain or functional dysphagia, and they restrict their eating because of that. So the first two groups, you get that long-standing pattern, and then the third group, you often see a much more acute presentation. Okay, next slide, please. So ARFID has only come into be diagnosed since DSM-5, and since then, I think a number of studies have been done to show that actually there's quite a variation in prevalence. In North American pediatric centers and eating disorder programs, there were 5 to 14% prevalence. A community-based study in Switzerland showed, 3% prevalence. And I think there's a big Australian population-based study, but mostly older, so greater than 15 years was 0.3%. What we know is that in ARFID, males outstrip females. They tend to present younger, and they often have a comorbid medical and psychiatric disorder, as mentioned earlier. Anxiety is really, really common, was present in 50% of ARFID patients in one study. OCD and autism spectrum disorder is also common. And what is also important is that they can become as unwell and as malnourished as in anorexia. Next slide, please. So if we look across at this table, might help kind of differentiate between the disorders. So with anorexia and atypical anorexia, there is a significant weight loss or a failure to gain weight. So yes, but not in bulimia, and ARFID there could be. In anorexia and atypical anorexia, they are underweight. In atypical, they're not yet underweight. So if you kept going, they would become underweight. Bulimia, they're often not underweight. And in ARFID, they could be underweight. Body image disturbance is present in anorexia and bulimia, but not in ARFID. Binge eating may be present in the binge purge subtype of anorexia and atypical anorexia, definitely in bulimia, but not in ARFID. And then the laxative use may be present in anorexia and bulimia, but not in ARFID. Next slide, please. So the best practice approach in primary care is trying to recognize an eating disorder early, making an assessment and providing appropriate referral. So largely it's trying to establish rapport, and sometimes it's actually hard to establish rapport with young people who kind of want to keep their eating disorder secret. I think it's making sure that physically that they are stable and psychologically as well, excluding any underlying physical illness, and then trying to put together a care team for the person, and then monitoring the medical and the psychological state as you go along. Next slide. So helpful questions on history. I usually try and take a history of an eating behavior over time to capture that ARFID population. So asking about what their eating was like when they were, weaning onto early foods, and what their eating was like as a toddler, looking at growth. And then Matt will go through some of the dietary questions a little bit more. I ask about, the pattern of avoidance of types of foods, or whether they're skipping meals or snacks or reducing portion sizes. I do ask about binge eating and purging. I look at what their maximum and minimum weight is, ask about their body image, ask about exercise, and important to put all the exercise kind of together, including PE, extracurricular sport, any private exercise, how much they're walking every day. In girls, I ask about periods, and then do a HEADS assessment to look at the context in which they present as well, and to also look at, what may be the triggers for the eating disorder developing. I ask about a family history of eating disorders or family history of psychopathology, because often eating disorders are, genetically linked, although, there's no one gene I identified for that. And I do a mental health assessment because comorbidity is really common. So ask about depression, anxiety, OCD, and also autism spectrum. as well. Next slide. I'll let Matt go.
Thanks, Michelle. Hi, everyone. So I'm just going to talk about what I see in one part of a dietary assessment from a dietitian and potentially what you might see in your practice. In taking a diet history, we're trying to understand how a young person is eating, but it's really vital information because it can open up a lot more of the discussion and a lot of the behaviors that someone might present with. It can certainly be useful in diagnostic clarification and an escalation of care if someone is presenting with behaviors or dietary intake that is unsafe, then it's certainly really informative information. It's really important that we ask specific questions on current intake. And it might be hard, as Michelle's mentioned, to gain the rapport enough to get the information that we might need, but the specifics of someone's dietary intake is really important. And so you might ask them generally what their food recall might be, what they usually have for breakfast, where they might be, what time that might be. And if that's too hard, you might go to just saying, can you think about yesterday and talk me through your full day, starting from breakfast and going through to when you went to bed. It's important to ask about quantities and portions, and asking family members or carers what they think of those portions also, because it might mean that it might look like, as they present or describe what they're eating, that it might be enough, or it might be a portion that we think is enough, but when you ask the carer, that portion might be half or less than what they would normally have beforehand. Thinking about diet products that are low in sugar or carbohydrates or high in protein foods are red flags. And it's important to ask when a change in the diet was noticed, what was happening, but what it looked like prior, because that can give us very good information on where we might go to with dietary modifications in the future if we're needing to go back to how someone was eating, because they were probably growing well at that point, and it might be where we're ending up later on. Next slide, please. Examples, I have a few of particular products when we're talking through a dietary assessment. Someone might say they have some noodles with some vegetables and some meat at dinner, but the specificity of your questions is really important. So there's noodles out there that are low carbohydrates. I've just listed there per 100 grams, which is a small amount, might be only 35 kilojoules and 1 gram of carbohydrates, but a normal regular noodle that you can find anywhere is certainly a lot higher than that. So that's what I'm talking about in terms of the diet products that are out there and the things that might be used to decrease energy and decrease weight, but we need to ask those questions that are specific. Next slide. Another one that I see very commonly is dairy products and them being excluded in the diet or reduced or changed to plant-based milks. I think it's important to note in terms of the comparisons between regular cow's milk or a plant-based milk, that they're not necessarily always comparable, and they could be serving as a function of decreasing total energy intake and producing weight loss if that's the case. It often starts with a young person thinking about healthy eating, and there's so much information out there that's so confusing for anyone. And often the slow changes might start to look good, and thinking about changing from a cow's milk to an almond milk sounds good in practice, but if that cascades in effect of different foods and different food groups, then that's also a red flag. Next slide, please. Example of a diet history of someone that I see is when we're teasing out what someone is actually having, they might be very good at telling me what their portions are and how much they allow themselves to eat. So for breakfast, they might have a shot of coffee if that's the case, but they might have only 25 grams of oats made with water, and 4 raspberries. It's very specific. It's a very specific amount of food, but it's very specific in energy, and that's a planned thing. Someone's sitting there and portioning out what they're needing, and that points to calorie counting. Once you tease that out, they might be going to school or university and saying to their carers or their families that they're eating throughout the day, but they might not be, because they might not be supervised. And they might be getting away with not eating all day until they get home. In terms of the meal behaviors that we see and things that we need to be aware of is regimented and inflexible eating. Being particular around how they might eat and what cutlery or crockery they might be using, because it's quite hard to eat when you're so anxious about the foods that you might need. And there's behaviors that happen, whether it be having a teaspoon might feel better to have smaller mouthfuls, but certainly that might be perpetuating what's actually going on and getting worse. Weighing foods is very common that we like to steer away from, but particular focuses on macronutrients and certainly micronutrients sometimes, but the big ones at the moment is carbohydrates. And used to be fats, they're still there, but carbohydrates is top of the list, unfortunately, with lots of messaging to do with nutrition and out there. Lots of observations of how parents might be cooking is common, and that causes a lot of distress around the meals, because the parents might be saying that we know you need some extra oil, but when they see that that's going in, what does that mean in terms of behaviors and escalations at meal times with mealtime distress? Next slide, please. This is another diet history example. I won't spend too much time on it, but it just does show the importance of understanding and asking what a diet looked like before a change and what happens now. Certainly you might not get that from the young person of what they used to eat, but their parents or their carers or their friends will definitely be able to tell you, and it will point to why the young person may have lost a lot of weight or become medically unstable. It's also really helpful in refeeding in terms of getting more energy back, because it helps to know what someone used to do and pointing out to them that they can do it again. Next slide, please. So things to look out for, as I've discussed, different products potentially with different macronutrient distributions, dairy restrictions to plant milks, but certainly high vegetables and high fruit intake is common. And it can look like we're eating a lot of food if we have a full plate of vegetables, but actually the amount of energy is very minimal when we compare that to meats or carbohydrates or dairy. Different diets in terms of veganism or pescatarian or vegetarianism can be diets that are that people can follow in a healthy way. But if it's leading to a deficit in total energy intake and inadequate growth, then it's not giving something that they need. Air or filler foods, rice cakes, puffed rice, they all look again like we're eating a lot, but very low in energy. So we need to be mindful of them. Caffeine intake is certainly something that can feel like someone's getting a bit of energy, boost things, but actually it's limiting. Next slide, please. Often I get questions about, well, how does an adolescent need to eat? What am I aiming for? What's a normal thing for an adolescent to eat in there? And it's very, very hard to say. It's very hard to know. This is the Australian Guide to Healthy Eating. This talks about all the 5 food groups. There's serving sizes recommended in there. It's an easy resource to access. Not everyone, certainly adolescents don't get all their fruits and vegetables in, but the key parts are there food groups that are being restricted or reduced. And a big part of it is the discretionary food at the bottom right-hand corner of the Australian Guide to Healthy Eating is recommended to have in sometimes and in small amounts. And if that's never, then that might also be a red flag, because it's okay to have those foods, but if they're completely eliminated along with food group elimination, then that's also something to think about. Next slide. I'm going to fasten up so we don't run out of too much time. Refeeding syndrome is something that I did want to mention briefly. This is something that we take into consideration in hospital and we manage very well. It's a process that happens in the body as a result of starvation when a young person or an adult has metabolically adapted to starvation. It is the breakdown that we see of lean tissue, and it's resulting in depletions of electrolytes, so potassium, phosphate, magnesium, and zinc. And it can occur when we reintroduce nutrition. It can occur within sort of day 0 to 3 or up until day 10 of starting someone to be eating more than what they have been to start their metabolism again and get their bodies working again. It's treated by still increasing and introducing intake, but we monitor and we replace those electrolytes very carefully and closely to reduce any negative impacts of when we reintroduce food. Next slide, please. So as I said, it is seen when the heart rate, the blood pressure, and the metabolic rate increases, and that increases the amount of hormone of insulin in the body. As the body starts to replenish and rebuild its stores of ATP and glycogen for energy. It sees a sudden increase in thiamine consumption, and the sodium moves out of the cells and into the serum, which means there's not enough in the cells for them to perform their function. We monitor closely daily bloods. It's something that can also happen at home, but the electrolytes are supplemented and corrected to reduce the risks of outcomes such as ECG changes or thiamine deficiencies and the complications that can occur from that. Next slide.
So I'll come to examining someone whom you suspect with an eating disorder. Certainly in children and adolescents, using a growth chart is very helpful, because what you can do is plot their height and weight and look at it over time. We do their BMI and BMI centiles as a measure, because BMI on its own changes over time. So the centile is actually a better measure of what their growth is like. And in terms of classification of anorexia versus atypical anorexia, we look at their percent median BMI, which is the percentage of 50th centile BMI. If anyone wants me to show them how to calculate that, I can do that later. We look at their temperature, because often they are hypothermic if they've lost a lot of weight. Do a lying and standing pulse rate and blood pressure to look for postural changes, such as postural hypotension and postural tachycardia. Look at their capillary refill and see how shut down they are when they're malnourished. I usually do a quick Tanner stage by showing them the Tanner chart and getting them to actually point towards it, because again, you can actually get pubertal arrest and pubertal delay from malnutrition. And I think one of the signs of significant malnourishment is cognitive slowing. They can be cachectic and they can have edema, and they have an inability to sit up, squat, and stand. So that's the SUS test. If you Google that, you find it. And then look for Russell sign as a sign of purging, or having the chipmunk faces if they're purging quite a lot. Next slide.
Michelle, just a heads up.
5 minutes? Okay, thank you. I'm going to go faster. So quick investigations, one, are mostly to exclude organic disease. So think about diabetes, hyperthyroidism, inflammatory bowel disease, and celiac disease. So we often just do a quick screen with an ESR, TSH, celiac screen, full word test urine, full word test of the urine, and a BSL. And then the other thing was to check for complications of malnutrition. So iron deficiency, B12 and folate deficiency. We check their vitamin D, do their electrolytes, including calcium, magnesium, and phosphate. Those are helpful in refeeding syndrome. And I'll talk a little bit about refeeding shortly. FSH, LH, and estradiol in females. Testosterone is not terribly helpful in males because it varies quite a lot. And we often do a bone age at diagnosis, and we also do a DEXA and repeat the DEXA yearly, especially if the girls have amenorrhea. And for boys, testosterone is really important in having bone calcification. So we also do a DEXA at baseline and every 1 or 2 years, depending on how long the eating disorder is going on for. Next slide. So if we go back 1 slide, Zaha, one more. Ooh, I think we missed one there before. That's it. What makes us worry is if there's very rapid weight loss over a short period of time, say maybe, more than 2 kilos a month, they're much more likely to become bradycardic. We're also really worried by a period of starvation or very low intake followed by, increased eatings, often because we've actually said you need to start eating, and that's where the refeeding syndrome tends to occur. And then if they're vomiting very frequently, of course, then there's hypokalemia and possibly hyponatremia and hypernatremia as well. Next slide. Very quickly talk about intervention. So with anorexia nervosa and atypical anorexia, the mainstay of treatment is FBT or family-based treatment. And then the next 2 levels of treatment are probably systemic family therapy and cognitive behavioral treatment, which is CBTE. Adolescent-focused treatment is also another individual therapy, but we feel that the family-based interventions probably work better and tend to keep children and adolescents out of hospital more, because I think with CBTE and AFT, you need some sort of individual buy-in, which is not often the case in anorexia. And then there are other level 3 interventions. With bulimia, there's probably CBT and FBT probably have the most effective treatments. And then I think ARFID's a really still wide open space because there's not a whole lot of trials going on. These are only just starting. So there's some evidence for using family-based treatment and CBT, which has an ARFID model as well. Next slide. So in terms of admission to hospital and when to send them to emergency, and who are the ones we admit, they're the ones that actually have significant electrolyte disturbance, certainly if their heart rate's less than 50 resting, and if they are hypotensive, so all those in red, hypotensive more than 20 millimeters of mercury drop. The rest in black are a little bit more relative. So if they have a postural tachycardia of more than 30, a resting systolic BP of less than 80, we usually do admit. They're hypothermic, if they have dehydration, certainly if they have any arrhythmias, they come in. If their weight's very low, so less than 75% of median BMI, or more than 10 to 15% loss in 3 to 6 months. Sometimes we admit when community management's not effective, or if they're so out of control with their binging and purging and exercising. We also admit if they're very young and need to put on weight because of growth failure. We bring them in, progressively increasing their weight as well. And this is on the Children's Hospital website. And there are good guidelines. The College of Psychiatry guidelines are they're largely more for adults. I would point you towards the MEAD guidelines, which are the UK guidelines. They're actually really helpful and provide a nice table for assessment of risk. Next slide. And then there are good resources for parents and carers provided by Eating Disorders Victoria and Butterfly Program. And I would put a plug in for the carer coaching and carer support courses that Eating Disorders Victoria runs as well. Next slide. See.
Thank you so much, Michelle and Matt. That was very informative. Thank you. So we will go on to our next part, which
this presentation will demonstrate how to access.
Oh, sorry. All right. So just a little bit about health pathways. So health pathways, if some of you are not familiar, they are written by GP clinical editors with support from local GPs, hospital-based specialists, and other subject matter experts. And the purpose of following health pathways or devising health pathways is that it reduces variation in care and gives us some referral pathways that where the most appropriate hospital, community health service, or allied health provider would be available, and what services are available to our patients in our local community.
This presentation will demonstrate how to access
don't-
and navigate health pathways.
I think I'll leave that
to
one.
find relevant pathways and refer.
And
This
just,
slide provides a list of
sorry, just in
Health
view of
Pathways
time.
Melbourne is available to general practice teams at
Yeah, but you can scan this QR code and register for health pathways, or you could just type in health pathways and register there. Just because we are running short of time, I am going to go to the case studies. We would have two parts to the case study. We'll